Hi, I'm Lisa. I am with the SHARE project here in Haywood County, and we've been doing a series of interviews. SHARE stands for Spreading Hope and Awareness and Removing the Epidemic Stigma. And with each of these interviews, we've been trying to hit on those words: spreading hope, spreading awareness, and removing the stigma. And today's interview, like so many, covers all three of those. We're spreading hope in that recovery is possible. There are resources in the area, so we're spreading awareness. And of course, we're doing our part to remove the stigma just by talking about substance use disorder and addiction. So I am with Trevor Hermann today. He is with Meridian Behavioral Health, and we're just going to let him tell us a little bit about himself, tell us what your title is there at Meridian, how you got there, educational background a little bit. So give us just a little snippet of your history, if you would.
Sure. I appreciate you having me here, Lisa.
Yes.
Let me join your project.
Yes.
So I've been with Meridian. I first started in July of 2008 when I just had a bachelor's degree, and I worked as a qualified professional with adolescents that were involved in the court system.
Okay.
And I did that for 2 years, and then I went back and got a master's degree in clinical mental health counseling from Western Carolina University. And after that, I worked for Mobile Crisis in these Western counties for 3.5 years. And so I visited hospitals here in Haywood and Jackson and all the way out to Cherokee and Clay County.
Okay.
And saw people wherever they happened to be in crisis. And then after I'd had enough of that, I worked at the hospital here in Haywood County in a position shared with Meridian, doing assessments in the emergency department. And then in 2017, I came back to Meridian full time, still doing assessments for the most part. And then in the last 2 years, I've been in leadership here in Haywood County. And at the moment, my job title, which is a little awkward, is the Adult Services Clinical Lead for Haywood County.
Okay, that is a mouthful.
It is a mouthful, yes.
Okay, so you do deal with adults then primarily?
Yes, for the last nearly 10 years have seen only adults.
Okay. So tell me then, so your education, everything was geared towards mental health, substance use, addiction,
sort of.
It sounds like?
Yeah, well, my bachelor's degree is in mechanical engineering.
Okay.
And that wasn't a good fit. You know, I got through my degree from Arizona State University.
Okay.
But I think to skip ahead to one of your questions, that there's mental health and substance use in my family.
Okay, that's where I was going.
Yeah, I figured you might.
Yeah.
And so my mom struggled with bipolar disorder.
Okay.
And part of her bipolar disorder was she would self-medicate with alcohol because the mania was unbearable.
Yes.
And then the depression could also be unbearable.
Mm-hmm.
And she died in 2008 related to her illness.
Wow. Okay.
Yeah. And so that I had already started moving into mental health because of her struggles, and then that really cemented my decision to get a master's degree.
Yes. Okay. And at that time period, that many years ago, I assume bipolar wasn't. I mean, it was diagnosed, but not so much as how it was these days. There would have been some stigma surrounding that. I would think, seeking treatment.
Bipolar disorder was commonly diagnosed even when she first was diagnosed. I think I was only 21 years old, so that would have been 2002.
Okay.
It wasn't an uncommon diagnosis, but there certainly was stigma. And, I think what you've run into is stigma can be from any source. And what made getting her help so hard was not the system at the time in Arizona, it was her own family. Made it nearly impossible to get her the right help because of their stigma and shame associated with her diagnosis.
Yeah, wow. Okay, so tell me more about Meridian then. Tell me let's start by telling me what your day looks like. A little bit of a job description of what your day looks like, and then we'll kind of break down the services that Meridian offers.
So in theory, my time is split 40% still seeing clients.
Okay.
And then 60% administrative, overseeing our Recovery Education Center, which is like the front door to adult services at Meridian, where someone can come in and do a walk-in assessment and get set up with counseling. They can get set up with educational classes around recovery.
Okay.
They can do peer services. And so that's what in essence, the Recovery Education Center is, that first contact that most adults have with Meridian.
Okay.
Okay, and from there, someone may get an assessment in the Recovery Education Center or the REC. You'll hear that, REC. And from there, they may go into our substance abuse intensive outpatient program. And gosh, there's so many acronyms. So the clients eventually ran that all together, and they just call it PSYOP. So,
PSYOP, yes.
So
yes.
if you hear
I've heard
PSYOP,
that, yeah.
that's intensive outpatient.
Okay.
Okay. And so that's one of the programs I supervise at the moment. And so we run that program Monday, Wednesday, and Friday, and we do 2 groups each Monday, Wednesday, Friday. Right now they're still over Zoom.
Okay.
When we resume in-person services, hopefully we'll have a morning class that's in person and retain Zoom in the evening. Because what we've been able to do with PSYOP is actually get clients from all of our catchment area, because Meridian's not just in Haywood County.
Okay.
So not every county has an intensive outpatient program, because it's, it requires more staffing and requires a contract with VIA, but we really feel passionately that we'd like to offer that service to as many people as possible. So now we can through Zoom.
Yes. Okay. So is Meridian then just in Western North Carolina, or is
Yes.
it okay?
So Buncombe County,
covers
westward, and
okay.
not quite all of the westward counties anymore. We have limited presence in Cherokee, Clay, and Graham, only with our ACT team, which is another service that we have here in.
And so define that.
Yep, that's the Assertive Community Treatment Team.
Okay.
Okay, and so Meridian has the contract in Haywood and Western counties
Okay.
for ACT. And then if you were in Buncombe County, you'd see several other companies that also provide that service in addition to Meridian.
Okay, and what does that look like?
Okay, well that service has been around for longer than Meridian,
Okay.
and it's was originally designed to be a hospital without walls for clients that oftentimes found themselves in a mental health institution.
Okay.
And the goal of the service is to get them out of institutions and living in the community. And so on an ACT team, you have a psychiatrist,
okay,
and usually a nurse practitioner, and you have multiple counselors or social workers. You have someone who's dedicated to housing supports, substance use supports, employment supports, and you have multiple nurses.
Okay.
And so someone who's on the ACT team really has a pretty comprehensive set of services.
Yeah, it sounds like it.
Mm-hmm.
And much needed.
Absolutely.
Service.
Much needed, and the sad part about accessibility in North Carolina is, you'll hear this as you talk to professionals over and over again. North Carolina, of course, did not take Medicaid expansion, and that has hamstrung efforts to make services like ACT accessible to more clients.
Wow.
Because Medicaid is the only payer source for ACT.
Wow.
Well, there is a very limited amount of state funding that's funneled through VIA Health to Meridian for ACT, but it's
right.
Right.
Is ACT exclusively through Meridian?
In these western counties it is, because the contract for a service like ACT is controlled by VIA Health.
Got it.
And Meridian has that contract. But for example, like Mobile Crisis, whom I used to work for, Appalachian Community Services has that contract.
Okay.
So they offer that service in these western counties, and Meridian does not.
Right. Okay, I'm following. Yes.
Yeah, it gets
and they are
confusing.
but no, I get it though, because they are 2 different services. One is more crisis, one is bigger and broader and covers quite a few more things, it sounds like.
Yes, ACT is very much also a crisis service, but you're right, it's like a whole person, long-term service.
Okay.
Yes.
Does someone have to be a part of Meridian to access the ACT services?
We get referrals from all sorts of sources. We get referrals from the hospital here. We get referrals from hospitals in the surrounding area. If a client's going to be moving to our area and needs ACT services, we get referrals from DSS sometimes, Adult Protective Services. So no, we obviously do refer from within Meridian Services to ACT as kind of the highest level of care that we offer, but we get referrals from outside as well.
Okay. The ACT part of it then, do you have to be struggling with substance use disorder? Or
you don't absolutely have to, but most clients that receive ACT have a co-occurring substance use disorder and a mental health disorder.
Yes, which is very common.
Which is very common. Someone that's struggled for years with bipolar disorder, like my mom. I mentioned she's self-medicated with alcohol. That's a very common story for someone with acute mental health symptoms because it feels unbearable. and people seek relief when there's unbearable pain.
Absolutely, self-medicate.
Sure. Which is such a common story for someone who's in unbearable physical pain.
Right.
And they were maybe prescribed opioids.
Yeah.
And then the prescription of those opioids took on a life of its own and became its own problem.
Yes, absolutely. Okay, so you, in what you were just talking about there, including ACT, but as well as Meridian, you did break down some of the services there.
Yeah, we could keep going.
That's what I was gonna say,
Okay.
yeah, so, and of course, then at this point, let's make that specific to substance use disorder and addictions, if you can.
Okay, well, most of our
someone comes
services-
in, they go to the resource education.
Recovery education
Recovery,
center.
okay.
Yep.
And that's their starting point, so take it from there.
Okay, so the other places someone could go from the Recovery Education Center, we obviously have medication services, so we have,
Okay, you do.
yep, we have our CEO is also a psychiatrist, and our medical director, his name is Don Buckner, and he's worked in this area for decades. He's an excellent psychiatrist. And then we have Dr. Matt Holmes, who
Okay,
also,
familiar?
yep, and he has also worked in this area for quite some time. He's a psychiatrist for the Haywood ACT team. He also has his own business. He has a Suboxone clinic in Haywood County, and he has a methadone clinic in Macon County.
Okay.
So he's a long-term proponent of medication-assisted treatment. So someone from the REC could get into those medication services, including Suboxone therapy. Meridian does prescribe Suboxone. We do not prescribe methadone.
Okay.
Because it's a whole different game.
Yes.
Yes. We also prescribe other medications for treating addiction.
Okay.
The other ones that are commonly used for opioid use disorder being naltrexone, or its injectable version, which is Vivitrol.
Yep.
And we also prescribe, if someone we're struggling with alcohol use disorder, sometimes naltrexone will work, but rarely we'll also prescribe other medications that can help with that,
Right.
whether it was Antabuse or Camprol.
Okay, so then they have the access to that.
Yes.
What other things do they have access to? I'm assuming if you have a psychiatrist,
and as often the case, so someone would typically see a nurse practitioner or a PA for their routine appointments.
Okay.
And those providers work under our psychiatrist supervision.
Okay. If they enter especially your program with the medicated assisted treatment, do you encourage them to have a counselor? Do they have a counselor? I mean, is that just kind of part of the what you expect from them doing their part?
Well, so that's a hard question because, of course, we as professionals, or I'll speak for myself, I as a professional, having done this for some time, believe that it's helpful to have services in addition to medication, and the research backs that up. 100%. However, part of your quest to address stigma is to have as few limitations on good treatment as possible.
Right.
So, to answer your question in a long way, if someone comes in and what they really are interested in is Suboxone to help address their opioid use disorder, and they are not willing to have peer services or counseling or intensive outpatient, we're not going to tell them no about Suboxone, even though we believe, of course, that it would be beneficial to have other services. Right.
I can understand that, I mean, because you want their recovery journey to be their own,
Yes.
and hope that they might come around to some underlying issues related to.
And of course, when we talk about Suboxone to treat opioid use disorder, the first thing we need to talk about is safety.
Yeah.
The amount of risk someone is in from using opioids off the street, particularly now that fentanyl is so common, the risk is enormous.
Yeah.
So the first thing we could do to help them survive is to start Suboxone.
Absolutely.
Okay.
Yes.
And so what you just said is true. And once we start that, we hope that now that this window of opportunity is opened up in their life, and the risk is so much less, and they start to be able to put the other pieces of their life back together, that they'll see, maybe it would be beneficial to have some other services.
Yeah, absolutely.
But the first thing we need to do is help them stay alive.
Yes, absolutely. I totally agree with that. Do you find, if you could give us percentage, what is the percentage that come in and are looking for medicated assisted treatment, or just looking for another way to?
Gosh, now you make me wish I asked our operations staff to run some reports for you. I can't give you percentages.
Right.
I will say that, it's very rare for a week to go by, even in the limited client care that I do now, where I'm not talking to someone about starting Suboxone.
Yeah.
Okay. And even though I'm having the conversation, it doesn't mean that that person is going to go ahead and choose to start with our clinic. Okay. We have a clinic, but for a variety of reasons, it may not be the best fit for that client. Okay. For example, Blue Ridge Health, primary care provider in a federally qualified health center, or FQHC, just down the road, over by the hospital. They also prescribe Suboxone. And for many uninsured clients, they can do it for less monthly cost than we can. And they pass that on to their clients. And sometimes the best fit for a client isn't our clinic.
Right.
Okay. And sometimes it is our clinic, and we get them in as fast as we can.
Do you offer then those recovery education pieces?
Absolutely.
To anybody, even if they choose not to stay with
Absolutely.
with Meridian?
So we have we share clients with many other providers in the area. So for example,
awesome.
Dr. Holmes may see someone for Suboxone at Hazelwood Healthcare, which is his clinic, and he and the other providers there may decide they need more outpatient services than Hazelwood can offer, and they may ask their client to come to us for IOP or PSYOP or to Recovery Education Center classes. Or for example, Dr. Kreider has had a long-term clinic out of Mountain Medical where he works, and so he may see someone for Suboxone, and he'll require that they come to Meridian for at least one service per month.
Okay.
And so we see quite a few of his clients. So of course, if someone wants to see a different doctor or provider for Suboxone, they're of course welcome to come to us for other services.
Well, that's great. That's great though, that you do allow that instead of, closing it into just the
No. We absolutely encourage that if someone can get the right services, please get them wherever they happen to be.
Okay, so now you have referenced that word services a couple of times. So tell me, let's just say your example, Kreider.
Dr. Kreider.
Okay, so he refers and wants someone to take at least one service. You said. What are their options?
Okay, so that person would come and get an assessment at the Recovery Education Center, and that assessment would be with a licensed counselor or social worker. And out of that assessment, they would have recommendations. They would discuss with the client. I think it'd be beneficial if you came to our Recovery Discovery class, which meets every Wednesday at 6 o'clock.
Okay.
And come to that once a week.
And what does that look like?
It's an hour and a half class. It's all focused
My own curiosity.
That's all right. It's an hour and a half class. It's over Zoom right now. That's all focused on recovery from substance use.
Okay.
Okay. And
so just a learning. That one would be a learning tool. Then.
Absolutely.
Okay.
And then, maybe the person is struggling more intensely with substances, and we recommend that they come to IOP, which is 3 times a week, 2 hours each time, while it's over Zoom. In person, it's 3 hours each time. So, it's hard to say if Dr. Kreider only requires one service per month. We may recommend more. Right. And the client, it's their choice at that point.
At that point, they know they have to do at least the one.
And they may just do that one, and then we've had clients come every day to something because they are that devoted at that time to their recovery.
Any idea on average how many participate in the different groups? I mean, are we talking 3 or are we talking 20?
Well, okay, so it runs that full range. So in PSYOP right now, oftentimes in our evening group, it's more than 20. In our morning group, it's often more than 10. Okay, so on any given Monday, Wednesday, Friday, we may have more than 30 clients being served by PSYOP. Right. In Recovery Discovery, it's usually around 12 per evening.
Do they participate or do they just sit and listen?
We ask that they participate, particularly in IOP. It's a requirement that they participate.
Okay, so that would be kind of like NA in a way?
It shares some roots with NA.
As far as, it being like a recovery group.
Absolutely. There is that aspect of it that is a supportive group.
Right.
Part of being in recovery is growing some sort of community to lean on and share in recovery.
Absolutely. So you said that most are doing still Zoom. What's been your experience with that? I've heard mixed as far as, because such an important component is connection.
Sure.
And yes, you can connect on Zoom. It's very accessible. I love that part. And like you said, you can draw from different areas, so I think that is very good as well. Long term, I think when it first started, it was great. But long term, what are you seeing any negatives, or are you really hoping that part of this sticks?
Oh, I absolutely hope that part of this sticks and that we never go to an all in-person model again.
Okay.
But I absolutely hope that the accessibility that's offered by teleservices sticks around.
Yeah.
Do I also hope that we have more in-person services sooner than later? Of course.
Yeah.
Of course, because that connection piece is huge.
Yeah.
And some people really struggle to connect over Zoom.
Yeah.
And there's also, Zoom fatigue feels real to me.
Yeah.
After a full day of doing Zoom meetings
Likewise,
and sessions, I feel exhausted.
Yeah.
So I think we can just count our blessings that we had teleservices available in the last year and more of COVID.
Yeah, absolutely.
And my hope is that we learn something from that and the accessibility of it, and we never lose that.
Yeah, absolutely. I agree for sure. Okay, so you mentioned that do you have any kind of, you mentioned the word peer support. Do you have anything in the jails at all? Any, do you have anybody that's kind of like a linkage to care of somebody coming out of jail that you would steer them towards Meridian?
We actually have a program called the Linkage to Care Program, or TLC, that's in partnership with the health department.
Okay.
And we have a really fabulous person named Penelope, who is the face of that program, and she is so experienced in community mental health and doing outreach. And we are making efforts all the time to get clients referred from the jail straight into that program so that they don't fall through that massive crack that opens up when someone walks out of the jail.
Very quickly.
Yes.
Yeah.
We do not currently have services inside of the jail. There are 2 peer support specialists provided by Pathways in partnership with the jail that work in the jail, and then there's a part-time social worker.
Okay.
And a complication that people may not realize about providing services in the jail is that they're not funded.
Right.
Okay.
Volunteer, pretty much.
Well, there are grants that we're actively applying for, but when a person goes to jail, their Medicaid, if they have Medicaid, stops funding any service. Okay, so. All right, so for example, one of our ACT clients, someone that we've known and worked with for years, if they happen to be in jail, we're still going to see them, but we're not going to be compensated for that.
Right.
Okay, and that's true of any Medicaid funded service that someone could have. It stops as soon as they walk through the door of jail.
Okay. So following that, going down a little bit of a rabbit trail,
Sure.
Does that mean then if someone goes into the jail and they are already on Suboxone or Methadone and their funding then ends, does that mean that they don't get medication?
Great question. The answer is the jail has made great efforts to make sure that they continue medication-assisted treatment for existing clients that have an existing provider who is willing to work with the jail to make sure that they stay on medications.
That's good to hear.
And as far as I know, that is just Suboxone. Okay. But I would have to talk again with Jeff Haynes about, is that also methadone?
If it is just Suboxone.
But all those things also have to be in place. There has to be an existing relationship with a provider, there has to be an existing prescription, and the provider has to be willing to work with the jail while the client is inside the jail. If those things don't come together, as far as I know, the person is not going to get Suboxone. But there is not currently an ability to start Suboxone for someone who is in jail, which is a national push for clients who are identified as having an opioid use disorder to be able to start Suboxone in whatever setting they're in before they are released into a more dangerous setting.
Yes. Yeah. And your thoughts on that? Would you like to see that?
Absolutely.
Yeah, likewise.
I would say the same of the emergency department.
Yeah.
That's also a huge opportunity for Suboxone to be started, which again, going back to what I said earlier, is the first step in preventing an overdose for someone who has opioid use disorder. Yeah. And it is the clearest thing that could be done for a client to keep them alive in the midst of opioid use disorder. And the numbers speak really clearly to that.
They sure do.
Yes.
Golden. The medicated assisted treatment is the golden.
Well, the numbers are roughly 60% success for a client on Suboxone. And the numbers for someone with opioid use disorder doing non-medication assisted treatment, non-Suboxone, because other medications are effective but less effective. Say someone just comes and does psychoeducation classes and counseling, 10% success versus 60%.
It's huge, huge difference.
So find me another medical diagnosis where doctors would decline to recommend the 60%, recommend, successful treatment and opt for the 10% success rate treatment. And I think right there, that 50% gap is where you define stigma.
Yeah. Oh, interesting.
And lack of education about what medication assisted treatment is and what it's not.
Yeah. Very interesting. I like that. I'm going to have to think on that one a little bit. Yeah.
And that's, of course, my own interpretation of this.
No, and I agree. Lack of education is huge one as far as I think as far as stigma goes. Okay, speaking of stigma, do you find that your job, when you tell people what you do and where you work, do you find that there's a certain, stigma that follows what you tell people you do? Do you feel like you have to explain yourself?
No, I don't.
Okay.
But I am, I'll just own the privilege that I was born with. I'm a middle class, college educated, master's degree educated white male. Mm-hmm. And I don't have to explain myself in most settings. And I'll just say that really clearly. Yeah. And I can recognize that. Mm-hmm. That's benefited me in my career choices my whole life. Mm-hmm. So no, I don't have to explain myself, and I never have. Yeah. Have I experienced stigma against the mental health system? Mm-hmm. Absolutely. Interactions with law enforcement, EMS, and emergency departments over the last 10 plus years. Absolutely. Wow. But not me personally.
Right. Yeah. Yeah, and that's where you got to, I guess, separate it out. It's not,
sure. This has nothing to do with me.
Yeah.
It is a system that is not recognized or supported in the way that I think would be really helpful for our population.
How do you define your successes?
People that rebuild their lives. We have multiple peer support specialists that we employ that came through treatment programs at Meridian and other local providers, that they're alive today and they're doing good work today because they went through and did the hard work of treatment and recovery.
Yes. Yeah, I like it. All right. If there was one thing you could change, specifically here in this Western North Carolina area, Haywood County, if there was one thing you could change in the way treatment facilities are, the lack of treatment facilities, stigma, the whole wide gamut that is involved with the recovery world, the treatment center world, what would, if you had a magic wand,
all right, well,
what would you change?
There, of course, is a list, but the one thing that I think can make the most benefit in these communities, especially rural communities, is Medicaid expansion. Okay. Yes. 100%. And when I talk to, I'm pretty sure I've heard those words out of Sheriff Christopher's mouth. Okay. That the first thing that could benefit the most people and make services more accessible immediately would be Medicaid expansion. Of course, I have no control over that. That's a larger political issue.
Way larger. Yeah,
yes.
Way larger.
Yes. So that's unfortunate. Yeah. That there are political issues and hang-ups that are really stopping many people from getting the right help. Yes. And specifically Suboxone. Suboxone is not free. Suboxone costs a fair amount of money. If I had to take Suboxone, which I don't, thank God. That hasn't been part of my history. But if I had to take it, I don't know what my insurance would charge. But it would be totally dependent on the type of insurance I have. And then for folks that don't have insurance, they're usually looking at between $100 and $200 a month for the medication alone. Which is huge. Prohibitive for many people. And then for each doctor visit, it could be between $30 and $150. Okay, and so we're talking about people that are struggling to pay rent. They may not have car insurance because they can't afford that.
Yes.
And we're talking about now $300 or $400 a month set aside for this life-saving medication, which may not be doable. So.
Secondary then?
Sure.
Since that one's such a big one. Is there a secondary thing you would change?
Yeah, in Haywood County, I think there's progress, but so much potential for more coordination between the largest providers, such as the hospital, the jail, and anyone who says the jail doesn't provide mental health and substance use treatment is not in this reality. That's where most Americans who receive treatment, they get it inside of jail.
Wow.
Okay. So, if those two large entities and could work with the community providers in a different way to make sure that the opportunity of someone coming into the hospital or coming into jail needing medication-assisted treatment gets it started and then can move to an outpatient clinic, whether that's Meridian or Blue Ridge or Dr. Kreider, I don't care.
Yeah.
Get them into a clinic.
What is the holdup in that? A lack of a person that fulfills that bridge? That gap?
So I think there are a bunch of different holdups. One, I think stigma is a big piece of that. Okay. And then two, I think logistics are a big piece of that. Hiring and utilizing providers and keeping them. It's not inexpensive, and it's it takes training, it takes interest, and then the logistics of the emergency department saying, well, do we really want to start being a Suboxone clinic? If we start Suboxone, are we just going to have the same person that comes back next week?
Right.
And actually, some emergency departments in the country have done exactly that. That they are a weekly clinic for clients until they can be in an established outpatient clinic.
Interesting.
And I think it's, I don't know the logistics of that exactly, but I appreciate that someone's given it a go and trying to close that gap up from someone coming via EMS into the emergency department, having an overdose reversed, and leaving the same night.
Yes.
With no services.
Yes, exactly.
Right.
Exactly. Wow.
So I'd love to see those gaps close or shrink at least.
At least shrink.
Yes.
Yeah, wow. And it seems doable is the thing. It seems like it could be doable for somebody, some organization, somebody in there to. But you're doable, with work. But
doable with
it's
work.
not out of the scheme of making it happen. It seems like.
I hope that's really true. It just means a lot of people have to move in the same direction at the same time. Yeah. And organizations that have, maybe resisted that sort of movement need to move in that direction at the same time. So that does take a lot of work and coordination. Yeah. So I don't want to make it seem too simple. Yeah. Because there are a lot of moving pieces.
Especially when you have different organizations involved, like you said, Yeah. All right. Anything we missed? Any final message that you want to make sure, families take away? Anybody that's viewing this that knew nothing about Meridian until now?
Well, just to speak a little bit more about Meridian, it is a not-for-profit organization. It's been around since Smoky Mountain Center divested of outpatient or any face-to-face services. Okay. Smoky Mountain Center used to be an area provider that would see clients, and they also were the state administrator of services. Okay. That changed in the early 2000s, and it split so that Smoky Mountain Center, which is now VIA, they're essentially an insurance company. Right, that provides funding to, private companies that then provide services to clients. Got it. Meridian sprang out of that change. Okay. So Meridian. And it is not for profit. It is not for profit, which is rare. I didn't know that. Yes, it's and that's pretty it's essential to Meridian's mission. And Meridian's funding then only comes from grants and things like that? Most of our funding is funneled through VIA, through Medicaid and state funding, but also we receive grant funding, and like any not-for-profit, fundraising. Yeah. But that's a relatively small portion. Wow, well I'm quite impressed then. How long have they been around? You said early 2000s? Okay. And so Meridian also just roughly sees 70% of our clients are uninsured. Wow. So not Medicaid, not Medicare, not any insurance.
Yeah, wow.
And that's central to the mission of Meridian, is that clients need to have accessible services.
Yeah.
And that's central to the design of the Recovery Education Center, which is meant to be a place where someone can come any day and find help that day.
Yeah. That's great. That's great. Yeah, you guys have done very well then.
And I think the last piece that I'll plug as far as what's important in Meridian's mission is we talked about peer services, but only in a glancing way.
Mm-hmm.
We employ quite a few peers at Meridian. Like I said, many of them have come through services at Meridian or other local agencies. And that's central to our mission as well, is that our clients see examples of successful recovery, and we just understand that a peer can connect with a client the way I never can.
Yes.
Okay, I may have mental health and substance use in my family, but I don't have my own recovery story. And so the hope that I can instill is different than what a peer can.
Yes.
And we really believe strongly that that needs to be central to the work that we do.
I like it, yes.
Yes.
Because there is, you heard him say the word hope. Okay, there is hope. There is hope for recovery, and I agree. I think somebody that's gone through it can really show somebody that is in the baby steps in their recovery journey that there is hope. There is hope.
And then I think, the peer services overlap quite a bit with what you do, in that a peer can also be an ambassador to a family who may not know much about getting help in recovery.
Yeah.
And a peer may be able to give the right information at the right time to help that family kind of get on board with, this really is needed.
Yes.
That Suboxone really is a life-saving medication and not just some other opioid to be addicted to.
Can a mom come into your recovery education center and get information?
Of course.
Okay.
Can a mom come in and get specific information about their child who's in services without a release?
No, not that. Yeah,
No.
not that. But
No.
I mean, as far as, if they have a teenager at home and they don't have the clue where to start,
Of course.
can they come in and get information on,
We would always find
what
someone
even
to,
addiction is?
Of course,
For
we
some
would.
would be at the very, beginning stages of learning.
Of course. So we would always find someone who could come speak to that family member.
Yeah.
Hopefully a peer support specialist.
Perfect.
Yeah.
All right. Anything else, Trevor?
I don't think so. I think you've covered a lot of ground today.
All right. Well, thank you very much. I appreciate your time today.
Yeah, of course.